Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonia Barra, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Ibarra. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Hello, listeners, and welcome back to the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath. On today's episode, we will be discussing a recently published original science paper in the journal. The paper is titled Automated CT Staging of Chronic Obstructive Pulmonary Disease Severity for Predicting Disease Progression and Mortality with a Deep Learning Convolutional Neural Network. This paper comes to us from our colleagues at the University of California, San Diego. The lead author is Dr. Kyle Hasenstab, and the senior author is Dr. Albert Schau. The featured publication is a retrospective study that uses a deep learning-based approach to quantifying COPD severity. This approach is then utilized to prognosticate disease progression and mortality. This publication does a nice job combining principles of artificial intelligence, quantitative CT analysis, and pulmonary medicine. Okay, so in short, the investigators built an AI-based algorithm that quantified the degree of COPD from CT images. This algorithm was trained and tested on CT data from the COPD gene study. As a reminder, the COPD gene study was a very large longitudinal multicenter study of more than 10,000 patients that was done to explore the underlying genetic factors of COPD. In the current publication, the quantification of disease on CT was then translated to a CT-based staging of severity. The stages were mild, moderate, severe, and very severe. Using these stages, the investigators evaluated the performance of this staging system in predicting several factors: spirometric gold stage, spirometric progression of disease, and 10-year mortality. So here's the brief breakdown on the results. The CT-based severity system that the investigators designed had a modest correlation with spirometric gold stage. Furthermore, CT severity only modestly correlated with 10-year mortality. However, CT severity had a strong correlation with spirometric progression of disease, where the odds ratio was 2.50 of progression with very severe disease on CT. What's more, this correlation improved when combined with spirometric data. Most notably, in gold stage 2 patients that had very severe disease on CT, there was a 4.4 hazard ratio of spirometric disease progression. For the full results, I will refer our listeners to the paper. Okay, so a few questions. How did the investigators design this CT-based COPD quantification algorithm? How was the algorithm validated? Is this CT-based system ready for clinical prime time? Well, to address these questions and more, I had the opportunity to speak with the featured publication's lead and senior authors, Dr. Kyle Hasenstab and Dr. Albert Schau. Let's jump into my conversation with them now. Okay, so a few questions. How did the investigators design this CT-based COPD quantification algorithm? How was the algorithm validated? Is this CT-based severity system ready for clinical prime time? Well, to address these questions and more, I had the opportunity to speak with the featured publication's lead and senior authors, Dr. Hasenstab and Dr. Schau. Let's jump into my conversation with them now. All right, hello again, listeners, and welcome back. I am privileged to have with us today the lead and senior authors of our featured publication, Dr. Kyle Hasenstab and Dr. Albert Schau. The title of the featured publication again is Automated CT Staging of COPD Severity for Predicting Disease Progression and Mortality with a Deep Learning Convoluted Neural Network. Guys, thank you very much for joining me on the podcast.
Oh yeah, thanks for having us.
Thanks.
Yeah, happy to be here.
Perfect. Well, Kyle, Albert, why don't you tell us a bit about yourselves? What are your academic interests? Where do you currently practice? Kyle, why don't we begin with you?
Yeah, sure. So currently I'm an assistant professor of data science, actually in the Department of Math and Statistics over at San Diego State University. I've only been there about a year. Just before that, I was a postdoctoral scholar working with Albert in the Department of Radiology just across town at UC San Diego. I'd say in terms of my academic interests, in addition to data science education, obviously, I would say my primary interests are the development of applied methods, mainly statistical and AI methodology, geared toward medical image analysis. Sort of thinking about how we can make an immediate impact with those tools. Yeah.
Excellent. I love it. We only rarely have a lot of data scientists in the world of radiology and on this podcast. So thank you very much for joining us. Albert, how about you?
Well, I'm a cardiothoracic radiologist over here at UCSD and run an academic research lab. Was privileged to have Kyle as a postdoc for a little while a year ago. Seems like just yesterday. Yeah, we started this with the same real interest in trying to develop new algorithms, new approaches for analyzing image data and seeing what aspects of our current practice we could improve with AI.
Perfect. Well, then let's get into our conversation. But before we dive into the publication itself, let's get a little context on the importance of the work altogether. Can y'all give us a one-liner on what the biggest impact of this study is?
Yeah, sure. From my perspective, I would say that, well, we propose a CT-based staging system. So our proposed system for assessing the severity of COPD, and we've shown this is prognosticative of disease progression and mortality, in my view, can potentially improve the diagnosis and management of this disease. And we show that especially when using combination with the spirometric gold stages as well. So a little bit of a long one-liner, but I would say this is probably a two-liner, right? But just as important is, I think, the automation of that staging system using this AI technology, because it can help facilitate its use in clinic, as well as potentially increase accessibility to these tools.
Great. Yeah. From my understanding, your study combines COPD with CT staging with artificial intelligence, all towards taking steps towards creating a better clinical diagnostic and prognostic tool. Let's start diving into each of those parts. Let's focus on COPD first. Can y'all briefly review the spirometric gold staging system for us and how it impacts patient care?
Absolutely. So GOLD stands for the Global Initiative for Chronic Obstructive Lung Disease. And it's a system for staging the severity of COPD, except using measurements of lung function instead of lung structure like we're proposing. So these lung function measurements, they're measured by something, or it's a device or apparatus called a spirometer. And it essentially measures the volume of air during inspiration and expiration, right? So, and everyone's probably familiar with a spirometer. So using this device, two measurements are typically of interest. There's the total volume of air expired after full inspiration. They call this the forced vital capacity. So that's one measurement. And then another measurement they're typically interested in is the volume of air expired after a single second. So that's the FEV1. So essentially how the gold stages are created is they just place these thresholds, just simple thresholds on the FEV1 metric, along with the ratio between FEV1 and FVC. And using these thresholds, essentially you create these different partitions or stages of disease severity, right? Measuring lung function. So you have mild, moderate, severe, and very severe. And I would say that traditionally these gold stages are used obviously along with evaluation of patient demographics and symptoms to diagnose and manage the disease. But it's important to also note that imaging is actually not a traditional part of the diagnosis and management. So that's where our manuscript sort of delves into.
Yeah, great. That's a perfect segue to what I wanted to discuss next. We have a good idea of the clinical context. Now let's move on to the CT imaging next, which obviously, as you had mentioned, doesn't always play into the normal management of patients with COPD. Many of our listeners are certainly familiar with the qualitative descriptions of COPD on CT, including potentially the Fleischner Society descriptions of emphysema. Can you talk us through the potential incremental value of quantitative, not qualitative CT in evaluating our COPD patients?
Yeah, sure. So I like qualitative CT descriptions like the Fleischner guidelines, right? Because they technically are less time consuming than, say, manually placing ROIs, right? Just visually assessing the disease. They've shown that these qualitative descriptions are predictive of clinical outcomes. But a major pitfall is they are subjective, right? They can be prone to measurement error, inconsistent repeatability, right? There are studies showing lower inter-reader agreement using these. So there are definitely more advantages to these quantitative CT metrics, right? So quantitative CT measures, they're obviously more objective, so you can improve that repeatability. And potentially they can more accurately measure smaller structural imaging markers that might better explain lung function or better prognosticate clinical outcomes.
And Albert, how did you get sucked into the world of quantitative CT?
Yeah, it's an interesting question. When I was coming through residency training, we were told you don't diagnose COPD from a CT scan, and discussion ends there.
Yeah.
And I thought that was kind of interesting. The more that I've become involved in looking at the COPD gene data, and the more that I sort of listened to the pulmonologist talk, I realized that there's a shift that's happened and happened in the last several years, where people are becoming more aware that CT is providing, it gives us a better sense of how much of the lungs are actually involved with disease. And that the numbers that we can extract from CT are actually meaningful and arguably even maybe more meaningful than the spirometric measurements. So I think that that's something that's in a way a bit of a seismic shift from what I was trained. As we've begun to look at that, use that in our clinical environment, I'm beginning to see not just COPD, but a bunch of other diseases for which these quantitative measurements are actually quite helpful for. So,
and there's a lot to unpack there. You mentioned the COPD gene study. So the core of the data in your study comes from that COPD gene study. I think it'll be useful for our listeners to review the intent, design, and the results, the major ones at least, for the COPD gene study. Would you all be able to do that for us?
Yeah, sure. So I'm actually quite impressed with the COPD gene study. I've been working with the data from that study for a couple of years now, and essentially stands for the genetic epidemiology of COPD, right? It's this massive, massive multi-site study. The longitudinal study, they collect data on patients or research participants every 5 years. They have over 10,000 research participants, all heavy smokers with at least 10 pack years of smoking. I would say the overall aim of this study is to characterize the heterogeneity of this disease, right? And to do so using a variety of data modalities. So they have just tons of data, clinical data, patient demographics, their symptoms, their clinical outcomes, including exacerbations, hospitalizations. They also have spirometric data, obviously, for those spirometric measurements that I alluded to earlier. Something they do have is genomic data, and that's actually a data source I don't have too much experience with. I don't have much of a background in bioinformatics, so I haven't worked with that. But obviously, they also have CT imaging data. In terms of, you had mentioned their major conclusions. It's honestly difficult to summarize all the major conclusions of this study because it's such a massive study, right? If you go into the COPD gene website, under the publications tab, there's like over 400 publications, and it just keeps increasing every time you check. So I'm a little biased, obviously, because I work more with imaging, but the one publication that really stood out to me recently was the redefinition of COPD, right? Redefining the diagnosis of COPD. That came out about 2 years ago in 2019. Essentially, the investigators of the COPD gene group recommended incorporating CT imaging along with spirometry and clinical data into the diagnosis of that disease. And I think that's major because traditionally imaging wasn't really used.
No, that's perfect. It speaks to how robust the COPD gene study is and how many different conclusions we can derive from it. Obviously, your featured publication utilizing some of that COPD gene data. Before we dive into the data analysis within y'all's study, can we review how the CT acquisition involved in the COPD gene study might differ from how typical CT protocols are out in the community or even at other academic practices?
Yeah, the COPD CT protocol, it requires two acquisitions, right? You have an inspiratory phase acquisition, also an expiratory phase acquisition. And I'm explaining this in terms of how I understand it as a data scientist. But COPD, it's partly characterized by breathing problems, right? You have trapped air in the lungs, and this is due to airway obstruction, causing airway dysfunction. And so it makes sense to acquire images of the lungs that sort of capture the aspect of the breathing dynamics of a patient, right? So we do this by acquiring images at full breath hold and then at expiration. And then using these two images, we can actually quantify not only the amount of emphysema, but the amount of air trapped in the lungs. And normally, I think traditionally, air trapping was quantified only using the expiratory phase acquisition. But lately, we've been seeing value through our approach and through parametric response maps that you can quantify air trapping using both images simultaneously.
I'll just add to that I don't think I could have said it any better. The standard protocol that most people are using in clinical radiology for your standard chest CT is usually an inspiratory phase CT, and so what's missing is the expiratory phase. So we've incorporated that as a dedicated exam where we acquire both as part of a clinical exam now, which may differ from how most people are doing their typical chest CTs. And these are inspiratory volumes and expiratory volumes, not just individual slices.
Got it. And I think that point's important to clarify because some of us who might have experience with interstitial lung disease imaging may do non-contiguous acquisitions of data. But Albert and Kyle, y'all are saying that the data sets are volumetric, meaning they're the entire volume of the lung, both at inspiration and expiration.
Yes.
Great.
Yeah.
Perfect. Okay, so that's a perfect baseline for now understanding how y'all derive those quantitative CT metrics. I want to spend a little bit of time going through y'all's workflow in terms of how you're able to do that. But take note, me and a lot of our listeners are not necessarily experts at the convoluted neural network components. So before getting into the technical weeds, let's try to get through that two-part process that y'all describe in the publication. It sounds like it starts with segmentation, and then it uses deformable registration. Could y'all walk us through those two steps and how it's derived from the CT data?
Yeah, that's exactly right. So yeah, we don't need to go into the actual architectures of the deep networks or anything, but the entirety of the algorithm essentially consists of a lung segmentation CNN. So this is a deep neural network designed to segment the lungs and also the lung lobes, followed by a deformable registration. Now, this deformable registration algorithm just registers, or what you would say deformably aligns the expiratory image to the inspiratory image. And we do this to extract just two measurements, very similar to what spirometry does, right? Except a different modality. So we want to extract the percentage of emphysema, as I said earlier, and also something called the percentage of total lung involvement, which is just sort of a fusion including both emphysema and air trapping, right? So how the algorithm works is we just first segment the lungs using that lung segmentation CNN. Just creates a binary mask where you have ones everywhere there is lung, zero everywhere there isn't lung. And we use that mask with the inspiratory image to calculate the percentage of lung voxels that have very low attenuation. So attenuations below minus 950 Hounsfield units. And that is a threshold that's just been cited like crazy in the literature. It's listed everywhere in the literature, so that's where we pulled that from. So in a second step, we use the deformed expiratory image, right? We subtract the inspiratory image from that deformed expiratory image, and again, use that inspiratory lung mass to determine percentage total lung involvement. So all that's defined as is the percentage of lung voxels in that difference map, that attenuation difference map, with attenuation differences below 100 Hounsfield units. And that threshold was selected empirically in our study because that's sort of a novel thing that we've introduced within the quantification of air trapping.
Excellent. Okay. So that allows you guys to then quantitatively compare the two data sets against one another and derive some values from them. Y'all mentioned, you just mentioned some of those quantitative CT-based values. Can you explain how they translate to the staging systems for COPD?
Yeah, sure. So that's a great question because we thought about this a lot. We were thinking hard about this. How can we define a CT-based staging system using these measurements, right? And then we thought, well, why don't we parallel the spirometrically defined gold stages? So in other words, we can let the gold stages themselves sort of guide or drive the definition of these CT-based stages. So as I said before, the gold stages, they're defined by thresholds, right? And these thresholds are made on only 2 spirometric measurements. So similar to that, our proposed CT-based stages are also just defined by making thresholds or placing thresholds on our 2 CT-based measurements. So the way we selected these thresholds was by doing just this greedy empirical search. We just searched all of these thresholds that maximize the sensitivity and specificity of each gold stage. So in a sense, we defined just simple thresholds on those CT measurements that accurately predicted each of the gold stages. Now, with these empirical thresholds, obviously there are these long floating point numbers. They're not very practical to use. So we use those as a sort of guide to create these stages, these other thresholds, more practical thresholds that would produce or create these CT-based stages used for assessing COPD severity.
Got it. So without trying to reduce it a bit too much, you use the gold stage information as a, pardon this, but as a gold standard against which you compared the CT-based data in order to define thresholds. You made them a little more practical to work with, and that's the derivation of the CT-based staging system for COPD.
Precisely, yeah.
All right, great. Y'all describe a very nice method of adjudicating this analysis in the paper. I'll refer our listeners to the paper for that so that we can get to the quote unquote good stuff, the performance of your staging system. So how accurately did this CT-based staging system predict gold staging or just mortality, morbidity outcomes in general?
Yeah, so we actually used the CT measurements in 2 different approaches for predicting gold stage, right? There's prior to the thresholding, and there's after we created those thresholds in order to create the CT-based stages. So prior to actually thresholding, using percentage of emphysema and percentage total lung involvement just straight out to predict gold stage, the AUCs were actually quite high, right? We observed AUCs of 86% to as much as 96% for gold stages 1 through 4. After thresholding, they dropped just barely a little bit, right? Which is understandable because you're categorizing continuous data now. We actually observed sensitivities of 85 to almost 95% for each of the gold stages. Specificity did drop for gold stage 1. It was about 56%, but the remaining stages had specificities of around 75 to about 90%. So this was pretty expected, right? As we observed pretty strong predictive power for the more severe gold stages. It did seem that our imaging-based stages couldn't quite separate gold stages 1 and 2. And the way I like to think of that is it's not necessarily a bad thing, right? Imaging could contain other beneficial information that describe other structural mechanisms behind COPD, right? That isn't contained within the spirometric measurements. So although they are correlated, it's okay that they're not perfectly correlated. It just shows there might be some additional benefit to using imaging in addition to spirometry.
Fair enough. So the CT staging system performed reasonably well for the worse gold stages, but modestly for the better gold stages. As you're mentioning, though, there's far more information that could potentially be extracted. For example, can the CT-based staging system predict who will progress in terms of their disease or who has a higher mortality rate compared to other patients? Was there any of that information that y'all had attempted to analyze in your study?
Definitely. We incorporated that analysis into the manuscript. So we looked at spirometric progression as well as 10-year all-cause mortality and how spirometry and our CT-based stages were predictive of those clinical outcomes, both separately and in conjunction with one another. And what we found was quite interesting. So based on our analysis, we found that the CT stages themselves were actually more predictive of spirometric progression than the gold stages were. And this actually makes sense, right? If a patient is very sick, they're at end stage disease, they have very severe breathing impairment on spirometry, right? At gold stage 4, they can't really get much worse. Their spirometric readings are already very poor. The thing is, with CT-based stages, if a patient has very severe disease on CT, it showed to still have a predictive power in terms of spirometric progression. And what's nice is this is evidence that imaging could actually facilitate earlier detection of the disease. Obviously, we'd need to verify that in a formal study. But on the other hand, thinking about mortality, it sort of flips. So we actually found that spirometry is much more predictive of mortality than the CT-based stages. So we found that gold 4 patients had 7 times the mortality hazard of gold 0 patients because they're just very sick, very, very severe breathing impairment. And this is compared to the hazard ratio of 2 for the CT-based stages. So you have threefold, right, for mortality hazard for gold 4 patients. Not to discount the CT-based stages, it's still quite predictive, but it really shows that spirometry shows end stage, very end stage disease. Now, thinking about the added benefit of our CT-based stages, if used in conjunction with spirometry, right? So we actually did an analysis combining them, using them in combination with each other. And those results were actually quite interesting as well. So we had found that among gold 2 patients who had severe to very severe disease on CT, these patients had the highest likelihood of progression compared to the other groups. Right? And this is interesting because it highlights the added benefit of CT with spirometry. I mean, these gold 2 patients, they have moderately impaired lung function. They're not quite severe or very severe yet, but because they're so bad as indicated by CT, right, they're in danger of progressing to those severe gold stages now. And I already mentioned that when you're at those severe gold stages, I mean, the hazard of mortality is very, very high. So we want to avoid that. So the way I like to think of it is this result from that combination analysis defines a sort of tipping point in the progression of that disease, right? I mean, perhaps now we might be able to identify these patients a little earlier prior to the point of irreversible disease so that we can treat them a little earlier, manage their disease a bit earlier.
I think that point is excellent there. I don't think that CT is meant to supplant or remove spirometry from the management of these patients. We're always going to be doing spirometry in these patients, but having incremental value on top of spirometry is going to add so much to the management of these patients.
Exactly.
We could talk for days about the benefits of this methodology, but as with any science, there are limitations. We mentioned one in that the acquisition technique is not the most common with both the inspiratory acquisition. Y'all also mentioned a PRISM population, which I believe is an acronym in your paper. And the PRISM population is apparently a potential blind spot in the current method of analysis. Could you review that a little bit more in depth for us?
We actually had many conversations deciding what to do about this population in our study design, just thinking about it several times. So yeah, PRISM stands for Preserved Ratio Impaired Spirometry. These are patients who still have low FEV1 values, right? They're suffering from airflow obstruction, at least shown through these low FEV1 values. But the thing is, they also have a reduced FVC value. And because of that, the ratio between the two obviously appears preserved. So as a result, they actually don't meet the spirometry definition for COPD. They aren't formally COPD patients. But the thing is this, although PRISM patients have that preserved ratio, right, they don't formally have COPD, they're still sick, right? They still have increased respiratory symptoms, they have inflammation, increased mortality. I mean, they're shown to progress more rapidly. Typically, you have someone going from gold 0 to 1 to 2 to 3 to 4. These are patients that sort of skip that and drop right down to gold 2 or 3. So they're still very sick. Unfortunately, we did remove these patients from the analysis, and that's just because they didn't follow the spirometry-based COPD definition. That's just part of our exclusion criteria. But I would say that we're still interested in teasing out the advantages of imaging for characterizing this group of patients as well for future research.
Excellent. And with regards to clinical practice then, where do y'all envision this tool being used? Or if it's not ready yet, what do you need to see before it's used clinically?
Well, Albert can comment on this too. I'll just say this. I would say any institution where the assessment of air trapping is relevant in any way. It's actually being used for research purposes right now at UCSD. We've integrated it into the system. The images are available in packs. It's a standard imaging protocol that can be ordered by a pulmonologist, and not just for COPD, but the assessment of air trapping in cases of lung transplant. I believe Albert has mentioned obliterans bronchiolitis. He could probably clarify that.
Well, I mean, I think you're doing an excellent job, Kyle. You know, if I didn't know any better, I would have thought you went to medical school and was already a radiologist. You know, but yeah, I mean, I think what we essentially realized is that there's really no reason why we couldn't offer this as a clinical exam, not just for research, but for clinical management. We know what the endpoints are for diagnosing COPD. We can stage them with this information and combine it with the spirometric measurements that we're getting also. So we can certainly do that. But what I was surprised to find is that our pulmonologists actually were really interested in using this, not for our COPD patients, but actually for our stem cell transplant patients and our lung transplant patients, as they're looking for a bit of bronchiolitis, like you mentioned, and that was actually secretly my plan all along. Is that, you know, I always kind of looked at the COPD population as a really interesting, really accessible data set, public NIH data set that that could drive us towards a better way of sort of coming up with thresholds for defining the severity of disease. When I'm looking at an inspiratory and expiratory CT, I'm measuring the ROIs of the right upper lobe, right, you know, on both sets of scans, and trying to figure out, is there air trapping there? It may not show up as mosaic attenuation. It may show up as something really diffuse, and then I can't really tell unless I have the window leveling exactly the same and exactly right. I can't really tell whether there's air trapping there, and I always found that troubling. So now that we have this this algorithm, we can just run the CT, run the algorithm automatically, and then get the answer. Give that to our referring docs as quantitative data.
So are y'all currently using this clinically for your reference? Are your pulmonologists familiar with how to interpret this information as well?
Yeah, so maybe a few months now. We've incorporated that into a dedicated protocol. And before we had our system set up to automatically run the algorithm, actually, Kyle in the background was running it, and we were reporting a lot of these numbers. We have some interesting cases, but I don't want to sort of give away the next publication that we'll be putting out on that, the results of that.
And that's perfect. I think a lot of listeners are going to want to hear that there's still active work being done to continue to validate this particular tool, because while we have the robust COPD gene data set, we want to see it in real time, you know, and y'all are doing that actively. I presume, are there any other studies we should be aware of, or is that under the hood stuff a little too secret?
Well, it's not a secret that we've incorporated this into our practice. We've definitely pushed the envelope a little bit more than a lot of practices implementing AI into our everyday. But I see no reason why not. You know, in many ways, I see ourselves, this new era of AI is sort of like opening the door of new eras of surgery, right? Like you develop a new technique, you realize its value, you start to apply it into your patients that you recognize would benefit from it. I was sort of trained by very forward-looking interventionalists when I was up at Stanford in my residency, and they stitched together stent grafts long before there was a Cook developing them as a commercial product, right? Like they just made it and realized that this was the best therapy for their patients. And some people looked at them kind of crazy, especially the vascular surgeons. But they knew, you know, what they were doing, and they realized what the risks were and understood how to manage that and do the best for their patients with the technology that they were developing.
So, Albert, you touched on merging the fields of AI with clinical radiology. I think now is a better time than ever for discussing the platform of Arteris. Y'all can probably go into a little bit more related to what we just discussed about the CT-COPD staging tool, but help our listeners understand, first of all, what Arteris is and how they can get involved to help progress the science.
Yeah, I think we've definitely seen the last like 3 to 5 years almost an explosion of companies that are really interested in the space, helping radiologists and other physicians better diagnose disease with new AI technologies. What I kind of realized at some point was that I didn't want the companies to have all the fun. Right. So that's where Kyle and a number of other residents, postdocs have become involved in AI algorithm development. And, who's better to come up with the right algorithms, solve the problems that are most relevant to radiologists than radiologists themselves, right? In many ways. So what I've started to do and hopefully encourage other people to do is to start to look at the opportunities within their own clinical practice for what are the open questions, what are the open challenges that we have in our own practice, where do we really struggle in diagnosis, in helping our clinicians manage their patients. So what Arteris is basically a company that I started when I was a resident back at Stanford that helped to commercialize a software for 4D flow MRI, analyzes blood flow in the heart. And that gradually became a commercial product and everything, which we now use every day. But what I asked them to do is develop a platform that would allow any investigator to leverage that platform to run AI algorithms in their own clinical environment, so that they can test the algorithms, annotate if they need to, collect data in a way that allows them to further their algorithms and their practice. So I think that's kind of the opportunity that I hope other people will take up, and I imagine many other companies will want to help facilitate as well.
For our imager audience out there that does have a significant component of their population with COPD or any sort of obstructive lung disease, is there a way in which they can get involved from a research perspective with the COPD staging tool you've described in your paper?
Yeah, so Kyle's been doing some really awesome behind the scenes work and making that possible. So the algorithm is available through Arteris, meaning you could run your own data through it. I don't know if there's a web access to that right now, but you can certainly do some of that testing. And we started to do a little bit of testing with one of my colleagues up at Stanford to see how well it might work on the data that they're collecting from their own scans there.
This is really exciting, guys. Seriously, thank you both for joining us. Any final comments before we close?
I don't know. It's just a pretty exciting time, right? That sounds very cliche, but it's exciting that we do have algorithms that are now capable of automating tasks, automating radiological tasks specifically, like disease staging. And not only that, they're accurate enough to actually implement clinically. And that's what's so exciting about it. Another thing is these methods aren't just useful for automation, they're also useful for knowledge discovery and image analysis. So we can potentially use these approaches, use these AI techniques to discover new features in an image that might be considered imaging markers useful for characterizing disease, right? So that's something that I'm definitely looking forward to doing in the future.
I think that's pretty well said, Kyle. There's a bunch of things that we don't yet know, and we have a wide open territory to discover new things with this new technology.
Mm-hmm.
Kyle, Albert, thank you both so much for taking the time to share your expertise on the podcast. Really, really appreciate it from me, the Radiology Cardiothoracic Imaging Journal, and all of our listeners. Truly, thank you.
Absolutely. Thank you for inviting us to be here.
Yeah, likewise. Thank you.
Of course. And to our listeners out there, thank you for tuning into the podcast. If you like what you hear from us, please rate, review, and subscribe to us. Once again, my name is Praveen Ranganath, and we will see you next time.